I'll introduce Dr. Atway, who is a graduate of the Ohio State Pediatric Medicine residency program and has continued here on faculty as an assistant professor in our podiatry department. I've sent plenty of folks his way in the past, and it's been a great collaboration. Saeed, take it away.
Okay, thank you so much. Can you hear me and see my slides okay? Just checking. Yeah. Awesome. All right. First, I want to thank you and congratulate you all on this meeting. It's fantastic to have such a focus group and have a group that's able to lead this and bring everyone together. Talkington family and Dr. Ng and Alexion as well. And I am, as Dr. Ng said, a podiatrist, so obviously I'm not going to add much with regards to the endocrinology aspect of this. So my focus will be on the lower extremity, for all intents and purposes, calling the lower extremity fractures here stress fractures, as Dr. Ng alluded to. It's probably the best way to categorize these fractures. I'm gonna try to advance here. There we are. Okay, so just as an outline, so stress fractures versus traditional fractures, look at the differences there. Causes not related to HPP, mainly focusing on biomechanics and how that can contribute as related to HPP, treatment of those biomechanics or ill mechanics, and then focus on controlling of these mechanics long-term to prevent further fractures and manage these patients. So bone fracture pathology, bones can fail for two reasons. This is a single episode traumatic failure. I mean, this is a patient with appropriate bone stock, not necessarily any underlying condition, but then if enough energy goes through, an area of fracture will happen. As opposed to a stress fracture, repetitive loads causing an imbalance between that bone formation and resorption, leading to micro damage. And again, this is where we're gonna probably have most of the focus, and especially related to these HPP patients. So how do stress fractures develop? Muscle fatiguing, which does not allow that bone to be protected. And then the force, the physics goes through the bone as opposed to distributing that energy evenly. So muscular attachments concentrate forces, and that failure is what leads to a stress or a failure of that bone. Etiology, again, my focus here going to be more related to the biomechanics. Flat foot, overpronation, underpronation, which we'll get to specifically with HPP patients in their typical rickets or genuvarum position and how that can lead to excess stress in the foot. Weight gain, exercise or increased demand, poor shoe gear, poor control of those mechanics, and obviously that goes along with barefoot walking, because the best shoes in the world sitting in a closet, as I always say, don't do you much good. So. Specific to HPP patients, this is an interesting presentation. I wasn't able to track this down very well, but impairments in muscle strength and physical function at the Endocrine Society annual meeting. So I might have to tap into Dr. Ng to see if I'm able to track that down. But looking at these patients and how there may be failures in their gait pattern, either due to where they're predisposed because of the HPP or how they've developed over time. I mean, we learn to walk. It's not necessarily, something we obviously we don't come out of the womb walking. But if there's a failure early on where these patients are not able to develop appropriately, then their gait patterns are going to be altered. And how much does that contribute just as much, or does it contribute just as much as the disease state itself? We should go through, that bottom right corner image is normal gait pattern, stance phase for a particular period of time, swinging through. And if you're not able to do that, that's where you can have a failure. Then where does that foot meet the ground, and how does it meet the ground? This is where you're looking at in I can explain those images. This is a lower leg with a heel, essentially that, let's see if you can see my cursor, that's the heel bone. And then you have a varus gait. So you have an introduction of weight to the outside of the foot, where most of us do land that way. But then we pronate. So the word pronation is sometimes thrown around as a negative term. Well, you're meant to pronate. You're meant to compensate for how your foot hits the ground. But if you're not able to, if you have an uncompensated varus, then you're only going to introduce, or you're going to introduce excess weight and pressure to the outside or that varus foot. So that's what I'm going to kind of focus on here. The other issue is, in the lower extremity, in the hip to femur area, you can have what's described as a Trendelenburg's gait, and that's also been described in HPP patients, where you would load in excess, the entire trunk would load in excess to that hip. So the ipsilateral, the same side of your hip, as opposed to holding your trunk steady, you're kind of tipping over to one hip, or you can compensate, which I'm going to add to some confusion here now too. You can compensate and load to the contralateral hip when you're walking. So that gait pattern can lead to excess pressure on one side or another, not allowing for rest through that gait phase. So other causes, again, my focus being biomechanics, but there are also athletic activities, nutritional deficiencies, hormonal imbalance, and obviously the main focus here being the bone disorder. So, epidemiology, so 95% of all stress fractures are in the lower extremity. As far as, taking up weight and gait pattern, that's mainly the reason why that happens. We don't weight bear on our hands, so lower extremity is where you're going to expect that. Near 50% are in the tibia, so lower leg bones below the knee. Another 25% in tarsal bones, so that makes up just kind of behind the metatarsals all the way to the heel bone. Another 8% in metatarsals, which that's where Dr. Ng and I overlapped in a study looking at metatarsal fractures, and then 7 at the femur, at the level of the thigh bone, 6 to 12 in fibula. Typically, you see insidious onset of pain, and then that pain usually resolves with rest. Important to take in patient history, any trauma to look for, any abrupt type of fractures, exercise or even trauma where something could drop on a patient. So a patient that may not necessarily be as active, but something dropped on their foot, that's also important to take in, and also a reason to consider protecting a foot and not remaining barefoot in a home for a patient that is prone for something like this. So we tell patients that are prone to stress fractures or may have had stress fractures in the past, shoes in the house is something that may save you from a lot of trauma. So shoes, obviously general health, diet, and occupation. So how do I assess these patients? So physical exam, pain, where do you feel pain? Typically when it comes to metatarsals, lower legs, there's not a lot of soft tissue in that area. So once you push over those areas, you'll have a high level of suspicion. Usually you'll see some swelling, and sometimes you'll see the tuning fork. Maybe it was because no one knew in podiatry what to do with the tuning fork. So that's where we'd use it over stress fractures and kind of see if that would actually stimulate any pain. So that vibration through a tuning fork over a bone, as light of pressure as that may seem, can cause a significant amount of pain when there's a fracture. So I'll skip over this female triad. This is probably more related to patients with your athletes. And so we'll go on to how do we confirm these findings? Imaging, so traditionally X-rays, although stress fractures may not be recognized in upwards of 85% of X-rays. So sometimes can be faint or subtle. usually you'll have to correlate with clinical findings. So a patient that truly has pain in a particular area that leaves you suspicious, you'll kind of hone in on that area, maybe have a little more of an advantage than a radiologist in looking at an area and have a higher level of suspicion to diagnose a stress fracture. But if it's not seen, sometimes it does make sense to protect that patient, treat their symptoms like a stress fracture until further imaging is obtained. So just a picture here of a heel bone. You can see just that subtle sclerotic line. Again, hopefully everyone's seen my cursor right over that heel. So that's not necessarily an overt fracture in this view, but you can see that dense line that leaves you suspicious that there may be some abnormal bone turnover in that area. And then furthermore, in this other image, you can see a little bit more in the way of clouding around that area, so maybe even some early healing. What other imaging can be obtained? A bone scan, not always necessary and maybe a bit outdated, very sensitive exam, and may not necessarily be the right answer for patients with metabolic bone disease, as those patients may be healing from another stress fracture or another fracture, and this doesn't necessarily, the bone scan does not necessarily give you specificity to an area, will just show overall bone turnover in a generalized area. So what is the better option, or where do we kind of go for advanced imaging? An MRI has become more of the gold standard and can help detect stress fractures when an X-ray may not necessarily confirm your diagnosis. The downside of this, it is costly, sometimes difficult to get patients in because MRI has become the gold standard for a lot of diagnoses. So getting patients in for these can be a challenge. So here's a good example of something that you're seeing in the way of more of a subtle presentation on that lower leg or tibia here, and then more definitive in the way of an MRI, where you're seeing that patchy, bright bone in that MRI image. So that is an indication that is an active stress fracture, and this patient needs to remain protected for a period of time. The other thing I would point out here, there may be a bit more verum in this lower leg, again, for a patient with metabolic bone disease. That's an area where there may be an excess stress, and again, we'll touch on that when we get to more of the biomechanics here. Tibial shaft, also an area, just the front of the lower leg that is prone to that type of stress fractures, common in runners, but also with the mechanics of your metabolic bone patients, and your genu-varum can leave this area prone. The cortex of the bone itself is an area that is hypovascular, so that the outside portion of the bone, where the patients may come in complaining of more like a shin splint type pain or just overall aching type pain. And these do take a while to heal. I mean, you're looking at 4 to 6 months, barring any other bone disease as well. Fibula, so that's the outside bone, and that's an area where if you have a rotation, and we'll get to that image again here soon, a rotation where you're putting excess stress on the outside of the ankle when walking, that's an area that can be prone to excess stress and failure. Tarsal bone, or the heel bone, again, we talked about that on that previous image, where the heel remains in that supinated state when it impacts the ground and does not compensate, will leave this area more prone to stressors or a stress fracture. So it's important to control that. The navicular bone, I've got a great image here, where you can see, or you shouldn't see, there's not really an overt fracture on this X-ray. This is a foot that remains in supination so that it does not compensate to ground reactive forces. It doesn't pronate, and so stress is taken up in the navicular bone, as indicated by that little line here, and also it's an indication that this patient, or it was a good idea that we did obtain the MRI for this patient, because this is a fracture that sometimes does require more in the way of fixation. So metatarsals, again, Dr. Ng and I did overlap on a study looking at metatarsal fractures in these patients and as a window for diagnosing metabolic bone disease. Why are these patients, why are metabolic bone disease patients, HPP patients, more prone to this? It may be a product of gait patterns, again, going back to that Trendelenburg type gait where the hip kind of compensates for where the trunk is positioned. So looking at this image, you can see that the letter A picture shows a high arch or supinated foot. And then when you flex the toes, that should kind of rebuild the arch. Sometimes that doesn't happen. And if it doesn't happen and you're not reacting to the ground appropriately, then that pressure will be taken up in the metatarsals. Also looking at some of the tendons and muscles around that area that now may be weakened. And I saw the chat question is, why does that happen? I'm not going to venture into, that part of the explanation. Although I will say, when it goes back to patients that have had these problems early in life or as pediatric patients and have not developed, have not developed the musculature to support these bones as well. So 15% of patients will have continued pain even after healing. So you may reach a point where you look at a metatarsal and say, well, this appears healed. This appears as healed as it possibly will be. And I think the term earlier was, a pseudo fracture. That may be the end goal for some patients, where you will not necessarily appreciate complete osseous healing, but as long as they clinically can function at a level of what their baseline was, that may be the goal, and better serve those patients as opposed to leaving them non-weight bearing for a longer period of time, or in a boot or protective device that may alter their gait and then lead to other fractures or other imbalances that could lead to other. So the fifth metatarsal is the most outside bone behind the big toe. So that area is even more prone to failing due to its poor vascular supply. So that top image kind of shows where that blood supply comes from proximal in the foot, back here, and then also gets a nutrient artery out distally towards the toe. And then there's what we call a watershed area kind of in between, the green zone, if you will, that where neither really takes over, providing blood flow in that area. And so it can be a really huge challenge to heal those areas. If anyone follows sports, that's the typical Jones fracture a lot of athletes end up with, that does require fixation. So a lot of the times a percutaneous screw that'll function not only to compress that area, but also to almost, I hate to give the analogy of rebar, but almost like a rebar to support that area or give it a strut so that the bone isn't necessarily all that is supporting the person or the foot, but that bone screw is providing a little bit excess support. So here's an image indicating a Jones fracture, and that's one that did require that screw with that rebar. So again, going back to this image to try to reiterate with some of that description that I gave, and I know I blew through them quickly, all those different types of fractures that in the lower extremity that some patients that have a genu varum have, a weakened bone stock to begin with, and then a developmental limitation in gait. They can lead to excess pressure to the varus foot. So then excess pressure, again, to the outside where this fibula that we talked about is going to have excess demand. That fifth metatarsal sitting on the outside of the foot will have excess demand. That heel will also take up pressure in excess and have excess demand, as opposed to a foot that compensates normally or pronates, where that energy will be distributed through all the bones, muscles, ligaments appropriately, and that patient will not continue to impact only on one side. So that, again, is where I would consider myself the person to go to say, well, how can I help that patient? How can I prevent them from, lead them to heal, but also prevent them from developing further fractures in the future? And again, I think that presentation at the Endocrinology Society meeting and looking at gait patterns is important. I think that may be a part of HPP where my subspecialty may be able to come in and help as we're more informed. I mean, our residents have been, how Dr. Ng and I ended up linking up was, our residents rotate with him. And I can tell you, I'd consider our residents some of the brightest in the US, and they're, learning a ton from Dr. Ng and being able to say, hey, this is HPP. It's on their list of diagnoses now, as opposed to some of their colleagues across the country that may not have had that advantage. So how are we treating these patients acutely? A surgical shoe to help to distribute pressure so that gait pattern can be controlled. More than likely, it's a boot, so a protective boot where you're able to take that entire lower leg and eliminate some of those excess forces and say, no, let's just create one rigid structure in the lower extremity from, below the knee down to foot that may help force the entire lower leg to function together. A cast, so that would obviously leave the patient non-weight bearing completely. Again, these are considered conservative treatment, but not necessarily benign. When you talk about a patient that needs 4 to 6 months to heal, it's, to place a patient in a cast for that period of time would be detrimental to, continued atrophy, limitation in gait. So it's important to know what your goal is in having that patient heal. It may not necessarily be complete osseous healing on imaging, but get to the patient to the point where they might have a pseudo fracture and their symptoms are controlled. How do we manage these folks long-term though, once we get them to the point where they have reached their goal of either a pseudo fracture, a asymptomatic fracture, or complete healing? How do we prevent them from refracturing? So this is where your ankle foot orthotics or lower extremity orthotics come into play. So a solid ankle foot orthotics, so a solid AFO, would help control the mechanics of your Achilles and limit your leg movement so that excess pressure going into, especially a patient that would have a tibia or fibula fracture, would be limited. Also controlling the excess pressure of the Achilles and pulling metatarsal fractures into the mix and limit that. So that may be something to consider. And articulating AFO. So this is an AFO that would still allow the ankle to move up and down, ankle dorsiflexion, plantar flexion, but limit some of that varus valgus, so that supination to pronation. So with these patients with the genu varum, that would help to kind of hold that patient in a more neutral position and hopefully limit the excess pressure to the outside of the foot or ankle. An external AFO. So, when you talk about an AFO that goes into a shoe, you also need to consider how challenging these AFOs can sometimes be and fitting these in patients' shoes, or for the caregiver that's having to help that patient potentially put their shoes on. So we sometimes will recommend these external AFOs that are just attached to the shoe and then function as a brace that kind of helps distribute that pressure, that load weight bearing to the lower leg, and does not require as much of a strenuous, AFO that needs to be strapped in and takes quite some time to put on a patient if that patient is limited in what they're able to do with their upper extremities as well. As a podiatrist, I think we sometimes forget there's an upper extremity. I'm just joking. So lower profile options, again, going back to the idea of difficulty in placing these in shoes. There is a lower extremity, a lower profile option. We're able to control that heel motion, still allowing for ankle dorsiflexion or plantar flexion when appropriate with straps. So this is one that has straps that will allow for ankle dorsiflexion and plantar flexion. So you're still allowing that patient some mobility in the ankle, but maybe not, allowing it in excess by having that strap there. If it seems like it's not working for that patient, they may need to move on to a solid short AFO, but at least you have an option for an intermediate or something in between. So we work very closely with our ped orthotists and orthotists in Central Ohio to provide these for patients. And, there is trial and error to some degree with some of these devices. So I know for some patients, they'll, see a device like this and say, there's just no way, I can't see myself using it, it's too bulky. Being sensitive to the fact that cosmetically, these are not necessarily the most stylish things for patients to wear. So we'll kind of work with patients, and the ped orthotists are pretty sensitive to those things as well. And then simply just an orthotic itself. So some patients, and again, I appreciate the previous discussion and talking about grades and severities of HPP, and maybe for a patient that's only had, a stress fracture and has gone on to heal, and it was a mild stress fracture, something as simple as an orthotic that you wear in your shoe that would help control some of that varus valgus play in their heel, that would more function prophylactically as opposed to a true AFO device that would control their mechanics long term. This is something that I prescribe for, I wear one myself. I mean, not necessarily have an extreme abnormality to my foot, but at the same time, I find that it's helpful to prevent further injury and abnormal gait patterns. Thank you. So the keys that I just wanted to reiterate, exhausting conservative treatment with shoe modifications. I think that makes sense for these patients when possible. Having realistic goals and relating those goals to patients and with patient satisfaction, or patient expectations being considered here. Working with, again, very lucky to have Dr. Ng, so that I can kind of rely on him to say, is this patient optimized? Is there anything else I need to be considering for this patient? Or if they're as optimized as they possibly can be, this may be where I need to take over and say an AFO is probably our best bet, as opposed to putting a patient that already has limitations in their gait and their mobility in a walking boot that, again, could lead to some difficulty in gait and lead to a fall that could lead to something more detrimental, or a fracture that could lead to a big challenge in healing. And then surgical treatment options, again, having that holistic treatment plan to say, well, is this limiting the patient from having an appropriate quality of life, or a quality of life that is optimized, and how are we going to get that patient there? Is a surgical treatment option truly necessary for these folks? A metatarsal fracture for someone that wants to return to running, their college scholarship relies on it, or other factors need to be considered here, might require more in the way of a surgical regimen to treat them, versus a patient that may be better served in an AFO or device to protect their fracture or their gait pattern and get them to their baseline of care.